everyone, Assalamu alaikum and a very good day to all of you. I'm Dr. Tazeen and I'm here with RRR series of core surgical skills for all the exam going candidates for August 2025 exams. So we are here going to cover some important exam tested areas from the core surgical modules. So before starting the session, remember one thing that keep your passion and dedication alive. That is the key to success, and just stay focused. And while attempting the exam, your focus and your how you are able to analyze and interpret the questions, that is important. Okay, so keep that in mind, and definitely you are going to crack this exam in one go. If you have not subscribed the YouTube channel of StudyMEDIC, subscribe now and then click on the bell icon so that you can get access to these RRR series, which are going to play an important role in your exam preparation. So we shall be discussing few of the exam tested areas or questions from core surgical module, which are very high yield questions and which will help you in the revision as well. So the first question is that on deciding where to place your secondary lateral ports at laparoscopy, care should be taken to avoid inferior epigastrics where these vessels can be found. 2 centimeters from the midline, lateral to the lateral umbilical ligament, lateral to the medial umbilical ligament, medial to the lateral umbilical ligament, or medial to the medial umbilical ligament. So we have to remember that the inferior epigastric vessels, they are found lateral to the lateral umbilical ligament, and we can prevent the entry regarding laparoscopic injuries by keeping in view these anatomical features, that where these vessels are located. The deep epigastric vessels and the venicomicantes, they run besides them, and they can be visualized just lateral to the lateral umbilical ligament, and these lateral umbilical ligaments, they are the obliterated hypogastric arteries in all but the most obese patients. The second question is about the Palmer's point, that you have attempted to perform a direct entry for your laparoscopy and opted to undertake the Palmer's point entry. Where would you find Palmer's point? 1 centimeter from the left costal margin in the mid-clavicular plane, 1 centimeter below the right costal margin in the mid-clavicular plane, 3 centimeter below the left costal margin in the mid-axilla, 3 centimeter below the left costal margin in the mid-clavicular plane, and 3 centimeter inferior to the right intercostal margin. So laparoscopic entry points are very, very important. And as far as Palmer's point is concerned, it is on the left side, not on the right side. And it is 3 centimeter below the left costal margin in the mid-clavicular plane. Okay, so the preferred point of entry is 3 centimeter below the left costal margin, which is known as Palmer's point. A 19-year-old woman is undergoing laparoscopy for pelvic pain. How would you describe the correct technique for entry with the Veress needle? So now Veress needle entry, how we can remember that, how we can say that this one is the right entry: below the umbilicus horizontally and then pass the needle at 45 degrees to the skin. Enter below the umbilicus transverse plane and then pass the needle at 45 degrees to the skin. Enter below the umbilicus vertical to the skin. Enter at the base of the umbilicus and pass the needle at 60 degrees to the skin. And enter at the base of the umbilicus vertical to the skin. So basically, in case of Veress needle entry, we enter at the base of the umbilicus vertical to the skin. And in most circumstances, the primary incision for laparoscopy, it is vertical from the base of the umbilicus. The care should be taken to incise so deeply as to enter the peritoneal cavity. The Veress needle should be sharp with good and tested spring action. A disposable needle is recommended. The operating table should be horizontal, not in the Trendelenburg tilt at the start of the procedure. And the abdomen should be palpated to check for any masses and for the position of aorta before insertion of the Veress needle. And the lower abdominal wall should be stabilized in such a way that the Veress needle can be inserted at right angle to the skin. Next question says that a 62-year-old woman is due to undergo a hysteroscopy due to thickened endometrium detected as a part of investigations for postmenopausal bleeding. Which medication should be used to prime the cervix prior to hysteroscopy? Mifepristone, misoprostol, no medication is needed, no non-steroidal anti-inflammatory drugs, or vaginal estrogens. Always remember that for hysteroscopy, medications are not needed for the priming of cervix, and routine cervical preparation before outpatient hysteroscopy should not be used in absence of any evidence in terms of reduction of pain or rates of failure, or if there is any uterine trauma. The next question says that when comparing robotic assisted surgery for conventional laparoscopic surgery for gynecological procedures, what would be the major drawback of robotic surgery? Intraoperative complication rate, length of hospital stay, operative time, postoperative complication rate, and safety and effectiveness in gynecological surgeon. So we should always keep in mind that robotic surgery versus conventional surgery, the main aspect or the main drawback is basically operative time. There is uncertainty as to whether robotic assisted surgery or conventional laparoscopic surgery has lower intraoperative or postoperative complication rates because of the imprecision of the effect or and inconsistency among the studies. Moderate quality evidences suggest that these procedures take longer with robotic assisted surgeries, and they can be associated with short hospital stay following hysterectomy. And there is limited evidence on the effectiveness and safety of robotic assisted surgery compared with conventional laparoscopic surgery. 45-year-old asthmatic patient attends the gynecology clinic with heavy menstrual bleeding, and ultrasound scan suggests the presence of endometrial polyp. The patient is booked for outpatient hysteroscopy. What analgesia should be prescribed at least 1 hour before the procedure? So, if we are doing outpatient hysteroscopy, which analgesia can be prescribed to the patient? We should always remember that we can give paracetamol. Routine use of opioid analgesia before outpatient hysteroscopy should be avoided as it can cause adverse effects, and women without contraindications should be advised to consider taking standard doses of non-steroidal anti-inflammatory agents, or they can be given paracetamol as well. What is the preferred distension medium for outpatient diagnostic hysteroscopy? So the preferred distension medium among carbon dioxide, dextrane, glycine, isodextrine, or normal saline, we should keep in mind that this is normal saline. Uterine distension with normal saline allows improved image quality and allows outpatient diagnostic hysteroscopy to be completed more quickly as compared with uterine distension with carbon dioxide. The next question says that what pressure should be the pneumoperitoneum be maintained during insertion of secondary ports for the laparoscopy? Whether it is 5 to 10 millimeters of mercury, 12 to 15, 20 to 25, 30 to 35, or more than 35. So 20 to 25 secondary ports should be inserted under direct vision perpendicular to the skin while maintaining the pneumoperitoneum at 20 to 25 millimeters of mercury. A 54-year-old woman has had insertion of a mid-urethral retropubic tape, and following the procedure, there was a significant fall in the hemoglobin levels from 12.3 grams per deciliter to 7.8 grams per deciliter. Imaging investigations show the presence of retropubic hematoma. A decision is made to evacuate hematoma. What is the most appropriate incision which can be? Cherney's incision, Costner's incision, Maryland, midline, or Pfannenstiel. So we have to remember that Cherney's incision, basically it allows access to the retropubic area or the space of radius and also the pelvic side walls in order to evacuate and identify that what is the source of bleeding. So here, as we want to evacuate hematoma, Cherney's incision would be appropriate. Theoretically, what kind of injury related to laparoscopic entry should be reduced by Hessen's open technique compared to a Veress needle entry? Whether it is bladder injury, bowel injury, major vessel injury, splenic injury, or ureteric injury. laparoscopy, the most common complication or the most lethal complication can be the major vessel injuries. Okay, so that's why when we are using the open techniques, laparoscopic, the risk of bowel damage is 0.4 out of 1000, and of major vessel injuries, it is 0.2 out of 1000. So it is anticipated that open technique would be less likely to cause major vessel injury than the closed methods. Now moving forward to the extended match questions. There are 3 questions and then you are having options, and then we have to see that what would be the appropriate answer for these questions. So the question 1 says that a 32-year-old woman with heavy menstrual bleeding, ultrasound suggests an endometrial polyp. Okay, so what can be the options among all these options which we have to opt if we want to diagnose or if we want to treat that? The second question says that a 40-year-old woman with subfertility suspected intrauterine adhesions after repeated dilatation and curettage. So what can be the suitable option in that scenario? And the third question says that a 52-year-old woman presents with postmenopausal bleeding. Transvaginal scan shows endometrial thickness of 6 millimeter. So what can be the suitable option for this woman? And the options for these 3 questions are diagnostic hysteroscopy, operative, outpatient, inpatient with under general anesthesia, removal of retained products of conception, removal of intrauterine adhesions, removal of submucosal fibroid, removal of endometrial polyp, evaluation of postmenopausal bleeding, investigations of recurrent miscarriages, evaluation of abnormal uterine bleeding, retrieval of lost intrauterine device, management of uterine septum, endometrial ablation, and contraindicated, not appropriate. So the first question is basically that the woman, she is having endometrial polyp. So the answer would be that removal of the endometrial polyp, some organic pathology is there. So we have to go for the management of that. So that would be the most appropriate option would be among these, removal of the polyp. Second shows that the adhesions are there, and that then we can go for removal of intrauterine adhesions. This is Asherman's. Okay, so we can go for removal of intrauterine adhesions in 40 years old woman who is presenting to us with subfertility, and that would be the most appropriate option among these options. And the third woman is presenting with postmenopausal bleeding with endometrial thickness of 6 mm. So the most suitable option in this is evaluation of the postmenopausal bleeding. So hysteroscopy guided biopsy can be taken, but if we say just hysteroscopy, or if we say that evaluation of postmenopausal bleeding, then definitely evaluation of postmenopausal bleeding is more suitable option in that scenario. The next question says that a 29-year-old woman with primary subfertility, hysterosalpingography is inconclusive for tubal patency. Okay, so what can be the suitable options for this woman? The second woman is 26-year-old woman with acute lower abdominal pain and positive pregnancy test. Transvaginal scan shows adnexal mass. No intrauterine pregnancy is there. Okay, and then third is basically a 35-year-old woman with recurrent severe dysmenorrhea and deep dyspareunia. Ultrasound is normal. So among these options, what we have to do is that the first woman is coming with primary subfertility, and hysterosalpingography is inconclusive, that we are not able to find uh, uh, for tubal patency. So definitely we should go for diagnostic laparoscopy in subfertility cases, so that we can find out that what actually is the cause of subfertility. 26-year-old woman with acute lower abdominal pain and positive pregnancy test. Transvaginal scan is showing adnexal mass. No intrauterine pregnancy is there. So if intrauterine pregnancy is not there, adnexal mass is there, and pregnancy test is positive, so that is ectopic pregnancy. And the best management option for this woman would be laparoscopic management of ectopic pregnancy. So we are going with that option, that laparoscopic management of ectopic pregnancy can be the suitable option for this woman. 35-year-old woman with recurrent severe dysmenorrhea and deep dyspareunia, and ultrasound is normal. So deep dyspareunia is there, severe dysmenorrhea is there, reproductive age group is there. That sounds like endometriosis. We can evaluate the woman for endometriosis, as this can be the suitable option in that scenario. The next question says that a 42-year-old woman with large 10 centimeter intramural fibroid, symptomatic menorrhagia, family is complete. Okay. The second question says that a 23-year-old woman with sudden onset abdominal pain, ultrasound 8 centimeter dermoid cyst, torsion is suspected. And the third question says a 38-year-old woman with pelvic inflammatory disease, fever and adnexal mass is there. Okay, so whenever we are talking about the first question, 42-year-old, 10 centimeter intramural fibroid, symptomatic menorrhagia is there, family is complete. So we may need, as this is a large fibroid, so we may need conversion to laparotomy. Fibroid is too large for laparoscopic removal. This is a 10 centimeter fibroid. So we may need laparotomy for this patient. 23-year-old woman with sudden onset abdominal pain. Okay, that is sudden onset abdominal pain. Sudden onset abdominal pain, and if there is some adnexal mass, always suspect torsion. Okay, so if it is a torsion, then we are not waiting for further evaluation, as there can be necrosis of the ovaries as well. So we have to go for laparoscopy. The time frame for which we can wait for scan is just 4 hours. Otherwise, we have to go for laparoscopy. So here the answer would be laparoscopic management of ovarian torsion. Always remember that this is not oophorectomy. This can be cystectomy, but after detorsion. If they ask you the management options, so the first option would be detorsion. You can see that the blood supply can be, resolved to the ovaries, and then you can remove the cyst which is present. It is always never needing oophorectomy until and unless there is necrosis of the ovaries. 38-year-old woman with pelvic inflammatory disease, fever and adnexal mass. Okay, so laparoscopic management of tubo-ovarian abscess would be there. Fever is indicating that this is pelvic inflammatory disease. Adnexal mass is indicating that this is abscess or tubo-ovarian masses are there. Most of the time in case of pelvic inflammatory disease, when masses are there, these are abscesses. So if it is there, the gold standard for laparoscopy is gold standard for pelvic inflammatory disease is laparoscopy. So that would be laparoscopic removal of drainage or laparoscopic management of these tubo-ovarian masses. Another extended match question, 38-year-old woman with incomplete miscarriage and retained products seen on ultrasound. Okay, so if it is, these are the retained products of conception, we have to see that which one is the most suitable option in these scenarios. The second question is 42-year-old woman with intermenstrual bleeding and scan is normal. Intermenstrual bleeding is there, but scan is normal. And the third is 26-year-old woman with subfertility, normal hysterosalpingogram, suspected endometrial pathology is there. Okay, so the first question, when RPOCs are there, so definitely we have to remove the source of infection. So that would be retained products of conception should be removed. So the answer would be removal of RPOCs. The woman who is having normal scan but intermenstrual bleeding is there. So we have to find out that why this woman is bleeding. So there can be some polyp which can be source of bleeding. Okay, so hysteroscopy can be done for this woman to have a look at the endometrium. So diagnostic hysteroscopy would be the suitable option in this woman. Okay, and 26-year-old woman with his subfertility who is having normal hysterosalpingogram. Okay, so but endometrial pathology is suspected. If we are suspecting some endometrial pathology in question number 11 and question number 12, so the best way to have a look at the endometrium, whether it is polyp or whether it is submucosal fibroid or it is thickened endometrium, we have to go for hysteroscopy. So that is diagnostic hysteroscopy, which we are going to do with this woman? If they say that some polyp is already diagnosed, then it would be therapeutic. Definitely that is operative hysteroscopy. Okay, that then the option would change to operative hysteroscopy. So for attempting the extended match question, what actually we have to do, we just have to first read the question, make up your mind that what can be the appropriate answer, then just have a quick look on all the 15 options which are there. Okay, you may find one option which is suitable in the first few options, but at times the best option can be there in the further options as well. So you just have to go through all these options and then only you can conclude your answer. Okay, thank you so much for your attention. I hope this will help you in your exam, and I wish you all the very best for your exam. Have a great day. Thank you.